Why do we care so much about women's heart health? We care so much because heart health, so cardiovascular disease, is the number one killer of women worldwide, globally. Women are systematically less likely to be appropriately diagnosed, so they're more likely to get misdiagnosed. They're less likely to get the appropriate treatment. They're more likely to die from their cardiovascular disease. And all of that is because of systemic biases in how data's been collected, how medical knowledge has been accrued. And a lot of the information that we have about heart disease comes from middle-aged and older white men in America, which is not generalizable to women.
Welcome to the Motherhood Clinic, a podcast about caring for mothers after childbirth, led by clinical experience and real-life stories. If you're a new mum and ever asked yourself, is what I'm going through normal? Should I be worried? Or who should I ask for help? This podcast is for you. It's for anyone navigating those early weeks, months, or even years after having a baby. Each episode brings together voices from across the motherhood journey, from clinicians, experts, and mothers from all walks of life. We're here to help you feel more empowered in your unique motherhood journey. We believe in a better start to motherhood.
I think everybody's very different in the way that they want the information shared with them. So I agree with you. We've often had long conversations about here are your risks. Think about long-acting reversible contraception when someone's still just had a baby and just trying to focus on breastfeeding and on the ward where they will have a consultant ward round. And I agree. I don't think that timing is best because later on I've seen these women and they don't recall any of that conversation. So one repeated thing that we've had feedback is having given written information. And I think that's sometimes what the other initiatives such as a Figo pregnancy passport do. So it's like a little passport and trying to get them to fill it in and have that information at hand so that they can go back to when they're more ready to take this on board. We've been doing the timing of, it's very different. Some areas they will have dedicated hypertension clinics that they could, like postnatal clinics as such, that they could come back to, but that's not the case in all areas. But where we're doing it in the maternity day assessment unit is when they've had a chance to start recovering. So we're usually seeing them maybe a few weeks after delivery to then discuss that. And I have had different feedback. So some women have been so scared by the statistics that they've just said, I don't think I will ever want to have a baby again. And also trying not to go down that scaremongering pathway, because although they are at increased risk, it does not mean that they will definitely have these adverse outcomes. But trying to get them on board to say, look, because of this, we really want to help you to just optimize your health between now and say a next pregnancy, if you're thinking about that, but also for the future, because there's still in a little bit of its infancy in terms of how these lifestyle interventions can really impact on overall outcomes in the future. And I think sometimes it's just tailoring it as we try to all the time individualize patient care, just to try to bring it all together and take on board, say, other risk factors and try to counsel that way. But I think a lot of people find it really helpful to know that there are things that we can do. So if you have had hypertension in a previous pregnancy, we would usually recommend that you would take aspirin in a future pregnancy early on, from about 12 weeks up until about 36 weeks of pregnancy, and knowing that that can help reduce the risk of hypertension or placental complications in the future. So I think sometimes it's just trying to figure out when is a good time for them. I agree. I think some GPs are really on it, and some GPs, they've got so much to do. They may be less aware of these long-term health risks for women. So I definitely agree about, so the keystone, I really think the education of women, empowering them. And a lot of these women would then buy their own blood pressure monitors so that they can keep an eye on their blood pressure in that immediate period, especially if it prevents them from having to be hospitalized and for a longer amount of time. And then that's what leads into the thoughts around, so these challenges, how about the wearables that so many women are starting to engage with, and how can we use this information to perhaps prevent hospital admissions and also try to take accountability to look into how their blood pressure profile is, because I think a lot of it is the trajectory of the blood pressure profile and also other markers of health that they can try to work on optimizing in that first year and when they feel ready to engage with that.
Perfect.
Yeah.
No, that's where I'd love to go next. You talked clearly about the challenges that are presented, and what's coming across is this theme of tracking and monitoring, because it's just something that we don't, as consumers and patients, just naturally do. The analogy I come into is a bit like financial health, right? Where every month you get a statement from your bank telling you what you've spent, what you are, and it tells you if you're in credit or debit. You've got people like financial advisors to help you with this stuff. So every month, whether you like it or not, you're getting an update on your financial health. But no one does that with their actual health, right? In terms of where am I at? And I say that for ourselves included. So only recently we started the Thriver. We just saying, well, actually, it would be helpful, not every month, but every 6 months, to get like, what's your baseline understanding of your actual health? Which it's just not a thing that we do. We're not taught about that at school to, understand blood pressure. I mean, as a layman, I still don't understand it properly myself. So I'd love to go there next with you both in terms of if the idea of, on a periodic basis, we are tracking, monitoring and managing them, and what is it for that patients need to understand? And what are the self-serve options out there? Is this available on the NHS? Is it actually something you can get privately? For people that are interested to monitor their health and understand what we've just talked about, where do people go? And what do those routes look like, publicly and privately?
Yeah, really interesting question. So I think, one of the things that is really important to know about blood pressure monitoring in pregnancy is the need for a validated device. So not all blood pressure devices are made equal. And there's a great organization in the UK called Stride BP, as in taking long strides, Stride, which has a list of all the blood pressure devices that have been validated for use specifically in pregnancy, because pregnancy changes your whole cardiovascular system. So your heart changes, your resting tone changes. Preeclampsia is a pathophysiological state. Devices have to go through quite rigorous testing to make sure that they're safe to use. So if you are looking to monitor your blood pressure in pregnancy, please don't just, use your auntie's or someone else's. Make sure that you've got a device that has been validated, and you can find those on the Stride BP website. Obviously, if you're lucky enough to be issued one through your hospital, then this will be a pregnancy validated device, but that's really important to know. The other thing to know about blood pressure is that how you take it really matters. So the guidelines are things like, for example, you need to be seated. You want your feet to be supported on the floor on a little rest. Your bladder should be empty, so you pee beforehand, because that can affect your blood pressure. You shouldn't be talking when you're taking your blood pressure. You should have rested for about 5 to 15 minutes beforehand. So these are all the things that give you a accurate and reproducible blood pressure measurement. For women on medication, you should take it after your blood pressure medication to see the effects of that medication. So one of the things that's really interesting about wearables is that it's kind of breaking all the rules of how we take blood pressure, right? So because blood pressure is taken in this very sort of regimented way. And with a wearable, you might be running or in the shower or walking or asleep. And so, so I think this is going to be a really interesting field, but I would say it is still a sort of an early and evolving field. What we know is that the more we measure blood pressure, the more information we get compared to clinic blood pressure readings. So, sitting down in your doctor's office and getting your blood pressure taken. If you do blood pressure readings at home, and you write them down and you take them into your doctor, we get more information about your health. If you do what's called ambulatory blood pressure monitoring, which is sort of getting closer to the wearables, and that's where you put on a cuff and you have a little device and you wear it for the whole day, usually for 24 hours, that gives you even more information about a person's heart health. So what we're expecting is, as we start to get devices that are validated, and I say that because we're not there yet, to be used in a wearable fashion for blood pressure, I think we're going to start to get a lot more information, both about pregnancy risk, but also in terms of future heart risks, as we get more data, essentially. The challenge is that actually ascertaining blood pressure on a wearable is not straightforward. It's not like pulse or SATs that you can use, sort of sensors. It's pressure based. And so, there are devices on the market which are, for example, a pressure sensor. But if you can imagine, if you're typing, that affects the reading. So it's not accurate enough yet. Things like the Aura and Apple Watches, they give you a hypertension risk score, but they can't tell you what your blood pressure is accurately. So I would say be very careful about devices making claims about blood pressure. At the moment, the only way to accurately measure your blood pressure is through a traditional device. There is one wearable made by Huawei that has actually got a cuff in this isn't it. This is just a normal, it's got a cuff embedded in a blood pressure cuff embedded in the wristwatch part. So you can measure ambulatory blood pressure, but it's actually inflating and deflating, and you have to do it like this. And I only know this level of detail because we're running a clinical trial in the postpartum starting next year, where we'll be looking at this, so a closed loop of women using a wearable blood pressure wristwatch with Meggie technology to see if we can optimize blood pressure control postpartum in a sort of low effort way. So this is all coming, but it's research. It's not established yet. So I think we will absolutely get amazing information. And I think one of the things, Fiona, that you talked about, I think is really, really interesting is scaring women. You know, women have had a horrendous experience with preeclampsia. We then sit them down, if they're lucky, with someone lovely like you, who can explain to them a few weeks later to say, you know, what does this mean for my lifelong health? And then we're saying, you know, 4 times increased risk of chronic hypertension, 2 to 3 times increased risk of heart failure, stroke, heart attacks. You know, it's a pretty awful list. And I guess the immediate question is, what can we do about that? I think that's really important, thinking about, you know, so it's obviously it's bad news, but how can we change it? And the problem is at the moment, we don't have data to know what works. So that's a big challenge. We know about the risks, but we can't say, take this drug, or, you know, if you lose weight, this will make this much difference. We don't yet know what works to make a difference. Mm-hmm. And I think the second thing is that we don't have stratification. So at the moment, all women are told this is your risk. But the woman who developed preeclampsia at 28 weeks and has recurrent preeclampsia and has got a borderline blood pressure postnatally, probably, and this is my guessing, this is not proven, probably has a higher risk than a woman who developed preeclampsia at 41 weeks and it resolved within a week postpartum. You know, those risks probably actually are very, very different. But at the moment, all the studies bundle all those women together because of the way that data works, and the coding lumps together a lot of different severity of disease. So one thing that I think would be really nice for us to be able to do in the future is to be able to say, to personalize that risk so that we can actually target our efforts where the risks are the highest. So maybe for the lowest risk women, we can give a bit of written information, a bit of support, but actually where the risks are really high, you know, we invite these women back to a clinic and actually a structured program to really try and improve those outcomes. So I think there's a huge amount of work to be done here, but we're still early on. So I'd say right now, what can women do? Understand what blood pressure is, understand what the warning signs are, know what the numbers mean. If they have high blood pressure at any point, I think it is worth investing, if you can afford it, investing in a pregnancy validated cuff, and regularly monitoring your blood pressure and understanding what those numbers mean. You know, ask your obstetrician, ask your midwives, they know. And really work on keeping it well controlled, because that probably does improve things in the longer term, keeping it well controlled both during pregnancy and after birth. The challenge is getting access to your healthcare professionals enough. But if you know what you need to do, then you can be the one, as Fiona said, you know, advocating for yourself, saying, you know, hey, my blood pressure's out of target. What do I need to do? You know, do we need to think about a different medication? What should I be doing? So that's where I think we are now. But in the longer term, I really hope we will be able to give better information, more personalized risk, and better tools, such as, you know, maybe wearables if we get to that stage. So to make this process as easy as possible, because as we've said, in the early postpartum period, it's really difficult to function, let alone, you know, manage a complex medical condition. So we need to make this as easy as possible.
Yeah, no, that sounds so exciting. I'm really excited about where this might be going and all the additional research that blood pressure wearable sounds really cool. But exactly as Fran has said, there's more and more research around that. A lot of the changes in pregnant women's hearts come on even prior to the onset of diagnosis of the hypertension. and preeclampsia. So in the future, when all of this is more validated and more individualized and followed up with outcome data, it'd be really interesting to know what their blood pressure profile and how their heart function is throughout pregnancy, and can we pick it up a bit earlier. Education is really key, but also there's a lot of strategies towards prevention, like with the aspirin. And so if we can prevent the severity of blood pressure problems in pregnancy, that would be great. And I do think there's really limited data around these outcomes for women in terms of long-term heart health and high blood pressure in the future. But there seems to be some sort of data grouping the just women who developed high blood pressure without another hit to their systems, with that often like preeclampsias, when they may lose a lot of protein in the urine or have abnormalities to, say, the liver function or the kidney function. But I think sometimes at the moment, when we counsel women, we do stratify a little bit based on when they developed it. So if it was a very early onset, more severe end of the spectrum, and it was preeclampsia, compared to when it was gestational hypertension without additional complications, and maybe a bit later on in pregnancy. Because yes, we feel that the disease mechanisms behind these two conditions are different. But I think it's incredibly exciting where this may lead to, but we are at this place where we don't have that data. And it's very hard to counsel women. But I think what we do know is that there's certain things that may worsen outcomes. So I think along the lines of the Figo pregnancy passport, all the work there, even though we don't know what's, certain things of regular physical activity, I think that's always going to be helpful for general health. But there are associations with, if there's increased weight gain in between pregnancies before embarking on the next pregnancy, there is evidence that that can make outcomes worse, and the risk of high blood pressure coming on early may be higher. So trying to avoid some of these things may be helpful. And that's the limitations that we have around advice for women in this situation.
We're being specific about what the research does and doesn't say. But as you're saying, there are general principles that will, as you're saying, will be timeless, irrespective, that will help mothers to improve. I had two simple questions. The first question was actually just really simply, like, how often should people be taking their blood pressure? So is that we talked about from the wearables, where it's always but not as accurate, but a point in time with a clinician could be every X number of months. So is there a viewpoint on how often they should be taking it?
Yeah. I mean, it's a great question. Of course, it varies dramatically depending on what the scenario is.
Okay.
If you are a low risk pregnant woman, then the advice would be to have your blood pressure checked at your antenatal appointments. It's your booking. It's sometimes you have a 16, don't you? Then it's sort of 28, 32, 34, 36. So, it'll be in line with your schedule of antenatal care. If you are higher risk, and someone has recommended that you monitor your blood pressure at home, or you want to do that at home, and your blood pressure is very normal, with Meggie, we say weekly. Whereas if you have high blood pressure or you're on treatment, it's daily. And again, at Meggie, we actually do morning and after and evening. So we recommend twice daily. Then interestingly, postpartum, it depends how things go. So if you remain with high blood pressure, you should keep doing it daily. Some women sadly will progress to chronic hypertension following, so long-term hypertension, having had high blood pressure in pregnancy. So essentially it just doesn't resolve, but the majority it will resolve. And so once hopefully you're able to stop treatment and your blood pressure has normalized, then the recommendation in the current NICE guidelines is an annual blood pressure check to make sure that your blood pressure is remaining normal because of that higher risk. So as with all things in pregnancy, it's very dynamic. It's never static. So it depends on where you are in the pregnancy. But I think, the key things I would say is antenatally as a minimum at your every appointment. And if you're higher risk or you have high blood pressure, you should be doing it more regularly, ideally. Postpartum, for as long as you have blood pressure problems, you should be doing it very, very regularly. And then in the longer term, if you've had blood pressure problems in pregnancy and it's now normal, a minimum of an annual blood pressure check, a bit like that MOT idea, every 6 to 12 months, you want to be checking in to see, is your blood pressure normal? Because hypertension is one of the single most, highest contributors to cardiovascular disease, so heart problems, and it's modifiable. You can treat it, and treatment makes a huge difference to outcomes. And I should couch this all, and I think maybe we haven't set the scene right at the beginning. Why do we care so much about women's heart health? We care so much because heart health, so cardiovascular disease, is the number one killer of women worldwide, globally. Women are systematically less likely to be appropriately diagnosed, so they're more likely to get misdiagnosed. They're less likely to get the appropriate treatment. They're more likely to die from their cardiovascular disease. And all of that is because of systemic biases in how data's been collected, how medical knowledge has been accrued. And a lot of the information that we have about heart disease comes from middle-aged and older white men in America, which is not generalizable to women as a starting point, let alone, other lines of ethnicity, geography, etc. So we know women's heart health is a major issue, and we're getting this information in pregnancy that you are at higher risk. And at the moment, the system is not geared up really to take you on that journey to say, hey, we've identified your higher risk. Let's do something about it so that 10, 15, 20 years down the line, we're on a different trajectory from where we are right now. Having said that, one thing I think that's really important to say is, and I think it fits in really nicely, this is a really good example of why we need these changes. If you look at the NHS 10-year plan that was published this year, they talk about 3 key principles. So one is analog to digital. We'll talk a little bit more about where digital health has a role here in terms of giving information, providing 24/7 support, all these things that digital technologies can do, and moving from treatment of sickness to prevention and health. So moving from a sickness service to a health service. And this is pregnancy and the postpartum is just such a great example of where that window is currently missed, that opportunity is missed. So we know that we've got information about someone's long-term risk, but at the moment the system isn't equipped to do something about it very well or very effectively. And we also don't really know what we should do to do this well. And then I think the last one is from hospitals to communities. So again, it's decentralizing medicine out of these hospitals where, it's hard to access clinicians in hospitals. I mean, it's hard enough to access GPs actually, but we're trying to decentralize care and health away from kind of institutions to being something that's embedded in your community and that's much easier to access. I think if we can follow all these principles in this particular space, so moving to the community, digital health, and moving from sickness to prevention, if we can do that here, we'll be making huge progress from where we are now.
Absolutely. Which is the whole premise behind the motherhood clinic, I guess. But I do agree with you. It's crazy that these blood pressure readings that we're saying is high has been extrapolated from data from men as opposed to women and as opposed to pregnancy specific data. So hopefully with more studies and real world evidence in terms of what are normal parameters and stratifying it by ethnicity and geography, that would be amazing. I think with the earlier question, I totally agree that timing of blood pressure monitoring both antenatally and postnatally is individualized and depending on whether treatment is being taken. And postnatally, we often do say daily. And I think one of the problems we have is that not all women will have access to a blood pressure monitor. So at the moment, under NHS service, there are still a lot of maternity units who will try to continue to set women up on home blood pressure monitoring and lend monitors, but monitors break down, they get lost. It's not like there's a finite number that there are available, and it depends on whether or not there's funding to keep replenishing the supply. So some women would have availability of a loaned blood pressure monitor, which is calibrated specifically for pregnancy. So they could do it on a daily basis. But if not, then often the community midwife would come out to visit them. And usually we know that blood pressure can often peak between day 3 to 5. So they would have more additional visits at that point just to see how whether or not treatment might need to be increased or might need to be seen. But I think in line with what Fran was saying about those ideals of moving, like going digital, if you can have oversight over these women who have high blood pressure who are at home and see how things are going, that's great. So a lot of units have also used a home blood pressure monitoring app so that they can see the blood pressure readings that women might be having at home. And that helps in a lot of ways in terms of seeing when treatment, we may be over treating as well. So we don't want it to be too high, but we also don't want it to be too low. So that's really helpful. And just looking at the trajectory, because if you do more frequent readings, and a lot of these medicines, although postnatally, we try to give the medicines in a way that's a once daily dosing, as opposed to a few times a day. If they're taking the dosing a few times a day, it's interesting to see how the blood pressure profile is. So they might need to have slightly more frequent testing, like Fran was saying, twice a day instead, just to get it right. And interestingly enough, I think most women may have a GP check at 6 weeks, but they do flag up for earlier GP review if needed. And a lot of women by that time are actually not needing the antihypertensives. That's something that I've observed from a follow-up of all women with needing medication, antihypertensive treatments postnatally, either having started it during pregnancy or just started it after they've had their baby. And I find that sometimes, because it's a blanket 6 weeks check usually, unless someone flags up something for an earlier review, we're often over-treating women because everybody's different. And they don't necessarily need to wait, bang, 6 weeks, I'm going to normalize my blood pressure like that.
Yeah.
So that's why I think everything that Fran said is really important in terms of enabling women to be safely monitored at home and like more timely surveillance and assessment of titrating treatment and checking for complications. Because yes, postnatally, that's when the complications are more likely to occur. So I think having such a service will be great. And then again, once you get that 6 week check, will they remember to have an annual BP check? So suggestion that even if not engaging with a postnatal service as such, when they go for the immunizations, when they go for the checks with the GP, that's a good opportunity to perhaps ask for a blood pressure check. These days, the pharmacists are also, you can book in to have a blood pressure check. That's another way of just keeping an eye on blood pressure and then making note of these blood pressure readings so they know what is normal for them, as opposed to what is normal for that 140/90 that's been extrapolated from male data.
So let's take a moment, because there's a lot of information, I think, for people to, again, for the layman in me to take on board, right? Let's imagine for a moment that I'm a woman just giving birth. And let's say I've been told that I'm high risk. I've bought into the idea of daily monitoring. My question simply is, what do I do with that? Like, as a consumer, what do I do with this? Like, it takes me a few weeks to get an appointment with my GP, or it takes me 6 months to see a clinician. So I'm bought into it. I agree with everything you just said. What do I do? What do I do with that?
I think it's such a brilliant question, Patrick, because this is the issue that one of the issues that we're grappling with at Meggie. So we have a tool which educates individuals on how to take their blood pressure, all the things we've talked about positioning, how to interpret the readings, like what do the readings mean according to clinical guidelines. That's where we have our software, Class 1 as a medical device, BP feedback module. So we're giving very specific feedback. We also have conversational support to talk about anything related to pregnancy, including blood pressure problems, to provide support through someone's experience. And then we have a data-driven dashboard for clinicians for easy decision-making so that the clinicians can see the blood pressures, know what to do about it. Say, oh, yeah, this patient needs to have less, this patient needs to have more, this patient's got, warning symptoms, let's bring them in sooner. The challenge here is the clinicians. Broadly there's a challenge in terms of women's adoption of technology and AI, and I think that's another conversation. But the real bottleneck is working out who is going to have oversight of those blood pressure readings. And the issue is that we're not dealing with systems that have lots of capacity, right? Where there's doctors are just waiting to have time and energy and resources. So the bottleneck is actually, I think, in many ways, is clinician time, because in some places that don't have existing blood pressure services, you're actually asking them to create a service or create a post for someone to start looking at these readings, when at the moment they don't. So one of the challenges here, I think, is really sort of top level in terms of, having the right recommendations in place at a national level to facilitate this being part of the job. And now, obviously, I think it's a really important thing to do, but we've got to convince this on a national level. These are the right things to do, and to prove that it changes outcomes and that it saves money and all the other things that we need to know for things to be implemented on the NHS. So I think that is the challenge, is who looks at it. And interestingly, we're doing work in the US where there are quite a few remote monitoring programs. What makes The challenge in terms of scalability, again, is the human resources. So in several centers in the US, which have got excellent remote blood pressure monitoring programs, they've shown that improves outcomes. They've shown that, women are more likely to take their blood pressure, more likely to be in control. Also addresses disparities across ethnic groups in terms of blood pressure, taking blood pressure, but they have to have nurse-run call centers. So they have a rota of 6 nurses to man the phones to be able to do this. And that's the piece that isn't scalable. The technology is scalable. The BP machines, you need the funding to, as you say, the churn of you lose some every cycle when you give them out and not all of them come back and some of them break. But the real limiting factor is the human resources, and those nurses then connect to their OBGYNs. So this is, I think, a really interesting space where, one of the things that we're looking at in terms of innovation is like which pieces can technology replace and which pieces are absolutely essential to be human. Because I think if we can make as many of these processes automated or able to be done by AI or technology, and then we're really asking the minimum from clinicians so that we're adding the minimum, just like we need the technology to be easy for women to use. Ideally, you want, a wearable that you don't even remember that you're wearing it. That's the perfect sort of wearable scenario, right? You need the technology to be really straightforward for women to use. We also need it to be really light touch for clinicians. Because if you're asking a lot from clinicians, they're very, very busy and they don't have time. So I think it's a really, really, interesting question. I don't pretend to have the answer, but, I think it's something that is really interesting to think about. Where could technology potentially, make this more scalable, remove some of these limitations in terms of the human resources that are currently required to make these kind of monitoring systems in place. So right now, what can you do with it? You have to, particularly postnatally, you'd have to find someone and show them. And I think that's where, find a clinician, someone who can prescribe a medication or make a recommendation about medication. And, that's broadly speaking, that's in the UK, that's doctors. So you'd need to find your GP. One of the advantages of using technology, so for example, the Mega Health platform, you are, chatting, asking whatever questions you need, popping your blood pressures in, and then Meggie compiles reports for you. So you can go to your GP, export your PDF and say, look, my blood pressure's been downtrending. It's been going down for the last 2 weeks. I think and it probably future versions will even have a recommendation to say, you could probably talk to your doctor about, should I be stopping my blood pressure? So we would never be making the recommendation, but making that, suggesting what is it that you should be discussing with your doctor, so that the data is there. So it's quick and easy. So even if you don't have a clinician plugged into the system, we're hoping to equip women and individuals with the information that they need to be able to have effective conversations with their healthcare providers to get what's best for them. And so that's sort of the next best thing, I think, outside of having clinicians in the loop, because it's hard. Clinicians and healthcare systems are very, very stretched.
Yeah, absolutely. So currently in the NHS, you would probably have community midwives initially and then refer on to the GP. Some places you may have a touch-in service with something like where I run with the maternity day assessment unit to have a review there. But other than that, I think after 6 weeks, it's usually, if you needed to seek help with blood pressure readings, it would be to see your GP.
I'd love to come back on a point and a bit of framing around this interplay between the future of the need to free up clinician support and the role of AI and where that goes. And then we'll think about how we round out this conversation. So the first point, I think, as you mentioned, Fran, is there is a bottleneck around clinicians, as we've identified. That is not to say that clinicians are the problem, right? So being clear about this is not like, we'll say like, you both are clinicians. We both know how hard clinicians work, publicly and privately. So this is more the call to action for more at the system level. How do we create capacity, space and headspace for that change to happen and for clinicians to have more time? And then the second element, as you identified, which is AI. There's a lot of scaremongering about AI taking over from robots, right? And like, I want to see a clinician, etc. It's not that. And part of the conversation we've been party to is actually, how does AI, because there is no other option, how can they augment clinicians' time? So this is about taking away the clerical stuff, the admin. I mean, the amount of time that you guys spend on writing up notes, getting a hold of language line, etc. This all takes away from clinicians' ability to serve other, patients and be the clinician. because so much of clinician time isn't clinical. So I think the conversation we're all raising, and I'm just more of a confirmation of what you talked about, this is about, it isn't about AI replacing doctors. So I think that's the avenue that brings a lot of hope and hopefully addresses some of the hyperbole and scaremongery what you might see in the media, where you're like, oh, your doctors are going and they're going to be replaced by AI. It's like, it's not that, so I think it's just that context I think is important to understand as people, and hopefully the adoption and willingness to accept, these more digital driven solutions, which are probably the only way that we start to address the shortage in terms of capacity. So we've talked a lot about the challenges that exist. I think hopefully people listening in will be clear about, why they should be concerned and what they should be aware of around hypertension and their blood pressure, what they can start to do about that, and understanding that these are individualized guidance depending on your situation. I'd love to round out with a question to you both. Given everything we've talked about the importance of monitoring our health, what does a better start to motherhood look like for you then?
Yeah. Oh, it's a great question. I mean, I think one of the things that I think I regret in my first sort of my transition to motherhood is not thinking about my health and my needs, and thinking about like, what support do I need to be able to give what I need to be giving to this teeny tiny baby. So I think having giving yourself time antenatally to really think about who is your team, who are you going to call if you are getting absolutely no sleep at night, which is a possibility. Is it going to be family? Are you in a financially resourced position where you could think about a night nanny? Who am I going to call if breastfeeding isn't working very well? Who is going to who am I going to hang out with for the next potentially 6 to 9 months that's going to help keep me sane when this gets really tough? So I think having supporting, it's such an enormous transition, and there are so many things going on, and there are so many things which are unpredictable, and I think that's one of the things that's really hard for people who are used to being in control of their lives.
Yes.
A lot of that just goes completely out of the window for years before you can finally feel like your life is back to something that's sort of vaguely in your control. I think having sort of getting your team together, and it sounds like a funny way to say it, but knowing who is going to be on your team, like who can you rely on, because you'll need different people for different things, and knowing that beforehand, like who can you rely on, is it paid, is it unpaid, like where are the boundaries if things go wrong, and particularly actually second or third time round, like what's going to happen. A lot of it is planning, like who's going to there's a lot of moving parts. So yeah, for me, if I could do one thing differently, I would definitely have set up a team, because I was just really unlucky that my husband became really ill when I was pregnant, and remains unfortunately severely disabled to this day. And we kept expecting him to get better, and he didn't. And I was on my own, and I wouldn't wish that experience on anyone, and I'm an obstetrician, like I should have known better. Like I knew what was coming, but I just kept thinking, it'll be okay. And I think just plan to potentially have a very tricky scenario. Think how am I going to make life work if I'm unwell, or if I've had a really difficult delivery, because there's a lot of things we can't control. And I think that's the other sort of piece of advice I'd give is, there are so many expectations around birth, postpartum, like bouncing back, going back to the gym, going to baby classes. Just try and ignore the noise. Basically, you have to find what's right for you and your newborn. And that looks really different for different people.
Good.
And, I think having to let go of some of those expectations and pressures from the outside world, and just focusing on you. Because if you're not okay, baby will not be okay. And, that's absolutely fundamental. And your relationship with your baby, and actually nothing else really matters for those early months. It's about you and the relationship with your baby, and having the people around you and the support around you, so that you two can get on with, you two or you three, however many of you there are, can get on with that. Because it's hard. It's really, really hard. And it's hard when you have all those expectations. So yeah, try and let them go. I know it's hard, but try.
No, that's great. That's really, really great. I love the point about just having your who's your A squad.
Yeah,
I love that.
exactly.
Who's your A team?
You need your A team. You need your A
You need your A
team.
team. Who's Mr. T?
Really
No, that's
joking.
great. I think, and there's a Fiona, any thoughts?
I wish I'd heard that before I had my children as well.
Was I not a part of your A team? Was I not there? Like,
Well,
separate
okay, let me
conversation,
focus on
separate
the question
conversation.
then. So I think there was a lady who I saw postnatally, and something she said really resonated with me. And this is so from that, I think this would be my wish for a better start for motherhood for all mothers. She just said that nobody connected things together. And she went to see her GP because she had back pain. And the GP said maybe it was because of the regional anesthetic that you had. So then came into our maternity triage, a little bit like an A&E, to see an anesthetic doctor about her back pain, was reassured about that. And there was something else that was going on. And then I was there more for her high blood pressure. And then, as you say, it's just so overwhelming. And she's come into the hospital. She's had to find someone to look after her baby. And she just said, I keep getting pushed from pillar to post and nobody connects everything together. And I think what I think would be great for women is having more of a holistic approach to that postnatal review and being able to have the resources to say, actually, if it's X, Y, Z components, maybe there can be a plan to improve things. And that's what I think is really missing in some of the gaps in postnatal care, because it seems to be if you need to see someone, it's for this one and there's that one, but you have to find those resources yourself or often have long waits to see these professionals. So I think just connecting it all together and trying to provide that sort of advice about how they can recover that period and how they can rebuild, and later on, how they can just optimize health later on. So because we don't know who they will see for that to happen. And even in the immediate postnatal period, I think it can be quite hard for them to navigate that themselves. So my thoughts are that it would be great if there was an integrated and coordinated postnatal recovery service. That's my hopes. And then I guess a little bit in line with what Fran said, like I think take all the time that you need, because even though we give all of this advice about you may have these additional risks if you've had high blood pressure in pregnancy, everybody takes a different amount of time to absorb that information. And you don't have to start with the lifestyle intervention straight away. Just take the time that you need. Because I think I was trying to push myself too quickly, and I'd get really annoyed at myself. And because I'm not used to it, and I think, oh, I'm an obstetrician, I should know a bit better. And I actually realized I knew very little about the postnatal recovery period until I went through it myself. And I think that's a little bit ironic, seeing as I am an obstetrician. So I think seriously, just take all the time that you need. And hopefully you will have your A team around. And even if you don't have your A team, I think a lot of women are in the same space. So it's really nice to try to connect and share to get through that period.
Great. Thank you, guys. A last one from me. I can confirm that doctors are the worst patients when it comes to looking after them. So that's why it's important to have your A team and people that can care for you, because motherhood isn't just about mothers, which is becoming another thing. Yeah, guys, it's been really helpful to have this conversation. I think we've got a lot to absorb from that. But it's been really insightful. And hopefully, again, our hope from this discussion is for people that aren't medical listening in, there are some clear guidance and education that they can take home for themselves, and to not feel like, things are bereft and the system's a mess. It's like there are things that you can start to do yourselves about this. So again, thank you very much to Fran and Fiona. And we'll call things a wrap there. Thanks, guys.